is used for multiple things. A lot of times when you see this, it'll be in the operating room. And there, hence the name Robert Jones dressing. Bulky Jones splint is another name for it. Most of the time, this will incorporate some plaster splints, especially if it's lower extremity. Although whenever we move up to upper extremity, we may not use this exact type of padding, but we will do what we call a formal hand dressing, which will incorporate a lot of the same ideas, which is more or less compression. Okay? So this will come in, and Tom and I, we roll this the same way, but different ways at the same time. Tom, I believe, uses half the roll, cuts it off, and rolls it in a 12-inch form, which is the way that this is. What I tend to do is actually cut it in half, because I just find it easier to roll. In 6-inch rolls. And why this is so important, because if it's not applied correctly, you're not really performing the function that you're trying to achieve with this dressing. Very expensive stuff too, by the way. Foot stamp. Something else you guys, this is going to be new to you guys. The neutral position for the foot, this is going to be for most casts, unless told otherwise, it's going to be a 90-degree angle at the ankle. Okay? In the best, most proper position for this bar to rest on is going to be between the 3rd and 4th metatarsals. If you rest it on the 1st, the foot will supinate. If you rest it completely on the 5th, the foot will actually pronate. So in most cases, between right around the 3rd, or between the 3rd and the 4th, you get a pretty neutral foot. What is neutral? Exactly the same way they go and strike the ground with their foot. Make sense? So when I put weight down, if I just let there and hang, I might be somebody who hangs in supination. I might be someone who hangs in a little bit of pronation. Most people will just kind of relax into a supination foot. One of the biggest errors you will see in rolling a cast or doing a bulky Jones is to actually supinate the foot. You don't want to do that. You want exactly the same way. If I was to put a piece of wood underneath her foot and just push her foot up as if I was putting weight down on it, that's the position that should be in. Okay? Ooh, web roll. You ever mean 4-inch web roll? 4-inch? Yes. Another one? Excellent. So the trick behind this stuff, also, to get 90 degrees at the angle, or at the ankle, is to make sure that the knee is bent to 90 degrees. Also make sure you have enough room to where you can wrap and roll between the back of the chair that they're on, or bed, and the back of the cast. Again, just like anything else, do you have to start out here? Probably not. You're not pulling this on. You're just kind of laying this on. You only need one layer. So I can stop. I'm not going to, though. I could just rip this off. But I'm going to actually use it all on her, because this is going to be for multiple different people. We're going to reuse this. Make sense? Mm-hmm. Actually, it ripped off there. Now, this is where the Jones dressing really comes into play. You want to compress this. You don't want to roll your web roll like you typically roll your web roll in a cast. When you roll your web roll in a cast, you're holding it way out here. Am I right? With the Jones dressing, the first layer must be compressed. And how you do that is you actually keep the roll on the dressing and compress down. You see how that happened? I'm trying to make this as tight as I can. You can actually hear it compress. And with all that padding, she'll probably tell you it still feels pretty snug down there, doesn't it? After surgery or acute injuries, some of the things we want to do is allow for swelling, but at the same time we need to compress them. This does just that. It compresses, but you have enough room in there to where if they were to swell, it will expand. And then what I do, just kind of make it look good once I've compressed it. Now I can go back, hold it like I typically would my web roll. Relax.
What are your parameters?
Your parameters are you are going out beyond the toes, supporting the toes, all the way to 2 finger breadths below the fibular head. Our fibular head is right here. I just happen to be 2 finger breadths below it. Now, there are multiple different ways to put your splints in this as well. So once you have something that looks like this, and the reason why I make you guys do this in the classroom instead of just seeing it, is this is the number one thing you're going to do at UCSD. They do this all day long at UCSD. And it's easy to do. It's one of the few things Mike will let you do right away. Everybody in surgery or who comes out of surgery gets one of these. Now, ace wrap, that's what we're going to use tonight. There's also a bias cut stockinette, which I've showed you guys in the past. It kind of looks like stockinette, except it's in a roll form like this. It's not tubular. That you will use typically in surgery. Now, this is only 5 by 30 splints. Don't write that down, because you want 10. But to save on some supplies, I'm only going to do 5. Okay? You guys only have to do 5 as well. Now, Tom will yell at you guys and make you support the metatarsal heads, curve it up to the calf. Okay? And his argument is this will hold 90 degrees. If I take this bar off of her foot's going to drop into what we call equinus. Okay? So you want to support the foot and hold it at 90 degrees. So supporting the metatarsal heads and curving it up is something that Tom does. At Kaiser, where I work, they want a posterior splint. Now Tom will argue that you don't need a posterior splint. Don't have to have it. And I agree. You don't have to have a posterior splint. Unless it's a calcaneus fracture, then you have to. But my doctors at Kaiser, they want a posterior splint, and they want some type of coaptation splint. When I first got to Kaiser, we did a posterior splint, and we did a coaptation splint just around the ankle. Since I've got there, I've got them thinking maybe move the coaptation splint a little further out to the metatarsal head. So I'm winning somewhat of a battle. But they still won't drop the posterior splint. It does add some strength, I guess. I don't know. So I'll show you, because when Tom comes in here, you're all going to say, because he'll demo this himself, or You'll see it Tom's way. You'll see it Mike's way.
No, I do use Socknet, and I do cut off the toes. Mine's a lot nicer looking than both of it.
He spends a lot more time doing it too, huh?
Do you use the posterior that you?
I don't know, do you?
Posterior.
Yeah. So he will go back and do a posterior splint just like this. Now, you will get the dog ears on the side. What I tend to do is fold them away from the patient. And I actually thicken the splint up just in that area, just around the heel. Then I've also done, instead of doing a full coaptation splint around, because I'll show you the problems with that as well. I've also just done struts. Remember how on the long arm posterior splint you did struts? I've done struts just from here to here. Okay? That's another option you have. But what I want you to do is support the metatarsal heads, come back, wrap it behind the calf. The problem with doing it this way is you get this excess splint material at the bottom.
You fold that down?
I actually folded it down. Actually double over the length right here to make it even a thicker strut. Now when this dries, this will hold 90 degrees.
So you fold it back just for support of the toes?
Yes. No, I didn't fold it at the toes. Oh, you mean just at the end? Yeah, just to double it over. This is the weakest part of your splint. That's bias.
At the U, you cannot use ace wrap. Everything you guys do will be done in bias.
We will use ace wraps in here because they're reusable. Bias really is not reusable. Okay? And to do it properly, you have another 4-inch ace wrap, or 4-inch bias.
We really do the bias go on like regular stuff?
Same way. It doesn't have as much of tension on it. So I will take, because I want to reuse my ace wraps, and cover my plaster. And just like anything else, you have to get them off the stand before it dries. If you don't get them off the stand before it dries, you will have an indent of that stand in the bottom of their foot. You will support and hold 90 degrees. Relax. Here's something else, people. Women, they put their knees together. Men, put their knees way out here for you. What does that tell you? Women will pronate. When your knee is in, your foot will pronate. Guys, supinate. When your knee is out, your foot's supinating. It's very, very rare that I come across it the opposite direction, where I see a guy doing this and a girl doing this. Very rare. When I do, I go, wow, it's a little different. See how nice form-fitting that looks? Now I'll be able to let go with this, and it will hold 90 whenever I'm done. No splint is made for weight bearing. Okay? I actually like even a better way of doing a short leg splint would actually be roll a cast in fiberglass using siphone, bivalving it, take the front portion away, throw it in the garbage. That's a great way of doing a splint. We don't do that. You won't do it at the U. You don't do it like that at Kaiser. They don't do it like that at Children's. But I've seen it done that way, and I actually like that the best way. By far the best way.
That's just personal preference at the place you're at.
Kind of, yeah. The difference between this and anybody else, these things are on for days, sometimes 24 hours. So I'm not going to spend a whole lot of time with this. The other thing too, like say you were in surgery, okay, most of the complaints, so this is supposed to be on for at least a week after surgery. These people are draining and oozing. 48 hours of draining and oozing, the blood next to their skin turns hard, coagulates. That starts to feel like plaster itself rubbing up against them. Your splint is nowhere near them, but they'll tell you, this plaster is rubbing up against my skin. It's not. It's their own dried blood. It's uncomfortable. Do you have to change it? Might as well check it. You will never change anything without a physician's order, first of all. Never. But that's something I would present to the doctor and say, hey, this person's wound is bothering them, wherever their incision is. Most of the time, the doctor will want you to change it just because he wants to be able to see the skin also. So I can let go, and it will hold 90 degrees. Nice, flat,